Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is 3klpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of prime neurology. There are going to be about 50 episodes of prime neurology, and if one listens to all these 50 episodes of prime neurology, one would have acquired a good knowledge of neurology. Right now we are on part 35, prime neurology, muscular dystrophy. So we are going to discuss muscular dystrophy in this episode. Muscular dystrophy. Introduction. Muscular dystrophy refers to a group of hereditary progressive diseases, each with unique phenotypic and genetic features. These disorders, of which there are more than 30, vary in age of onset, severity and pattern of the affected muscles. The majority of the dystrophies are caused by changes in the structural elements of the muscle cell, mainly in its membrane, but other important mechanisms are also being identified. Some dystrophies are associated with cardiac and ventilatory muscle involvement, which are the leading causes of death. Unfortunately, there are no specific medical therapies for most of the muscular dystrophies, and treatment is aimed at maintaining function with physical and occupational therapy. Pathogenesis. The muscle membrane contains a group of proteins known as the dystrophin glycoprotein complex that prevents damage when muscle fibers contract and relax. When this protective membrane is damaged, muscle fibers begin to leak the protein creatine kinase and take on excess calcium. This damages a muscle fibers and eventually causes them to die, leading to progressive muscle degeneration. Some forms of muscular dystrophy are caused by defects in the dystrophin glycoprotein complex. Others are caused by defects in the surrounding connective tissue. Still others are caused by expression of toxic gene products in muscle fibers. So these are the proteins involved in muscular dystrophy. Basically, the Duchenne's muscular dystrophy is caused because of the dystrophin protein alterations. So proteins involved in the muscular dystrophy. This schematic shows the location of various sarcolemmal, sarcomeric, nuclear and enzymatic proteins associated with muscular dystrophies. The diseases associated with mutations in the genes responsible for encoding these proteins are shown in boxes. Dystrophin, shown in the box, via its interaction with the dystroglycan complex, connects the active cytoskeleton to the extracellular matrix. Extracellularly, the sarcoglycan complex interacts with the biglycan, which connects this complex to the dystroglycan complex and the extracellular matrix collagen. The proteins involved in muscular dystrophies. Various enzymes are important in the glycosylation of the A-dystroglycan and mediate its binding to the extracellular matrix, and usually cause a congenital muscular dystrophy with severe brain and eye abnormalities, but may cause milder LGMD phenotype. Mutations in genes that encode sarcomenic and Z-disc proteins cause forms of LGMD and distal myopathies, including myofibrillar myopathy, forms of hereditary inclusion body myopathy, as well as Nemelin rod myopathy and other congenital myopathies. Mutation affecting nuclear membrane proteins are responsible for most forms of EDMD mutations. In other nuclear genes, mutations in other nuclear genes cause other forms of dystrophy. Pathogenesis. Although muscular dystrophy can affect several body tissues and organs, its hallmark is damage to the integrity of muscle fibers. People with muscular dystrophy progressively lose muscle function, which can affect breathing. In many forms of muscular dystrophy, the heart muscle is also affected, which leads to cardiac failure. Inheritance of muscular dystrophy. The muscular dystrophy can be inherited in three ways: autosomal dominant inheritance, autosomal recessive inheritance and X-linked recessive inheritance. In autosomal dominant inheritance occurs when a child receives a normal gene from one parent and a defective gene from the other parent. Autosomal recessive inheritance means that both parents carry and pass on the faulty gene. X-linked recessive inheritance occurs when the female parent carries the affected gene, passing it to the male child. The identification of types of muscular dystrophy. The types of muscular dystrophy are grouped by the extent and distribution of muscle weakness, age of onset, rate of progression, severity of symptoms, family history. Although some forms become apparent in infancy or childhood, others may not appear until middle age or later. Overall, incidence, rate and severity vary, but each form causes progressive skeletal muscle deterioration. Duchenne muscular dystrophy. Duchenne's muscular dystrophy is the most common childhood form of muscular dystrophy. Because inheritance is caused by mutation on the X chromosome, DMD primarily affects boys, although girls who carry the defective gene may show some symptoms. DMD results from an absence of muscle protein dystrophin. DMD usually becomes apparent during the toddler years, sometimes soon after the affected child begins to walk. Progressive weakness and muscle wasting caused by degenerating muscle fibers begins in the upper legs and pelvis before spreading into the upper arms. Other symptoms include loss of reflexes, a waddling gait, frequent falls and clumsiness, difficulty in getting up from a sitting position or when climbing stairs, changes in overall posture, impaired breathing and heart problems, cardiomyopathy. So this is the Gover's sign, typical Gover's sign of muscular dystrophy. Duchenne's muscular dystrophy. It shows a patient using his arms to climb up the legs and attempting to get up from the floor. Lordotic posture. It is exaggerated by standing on the toes, associated with trunk and hip weakness. DMD. The pseudohypertrophy. The calf muscles may be enlarged by an accumulation of fat and connective tissue, causing them to look larger and healthier than they actually are. As the disease progresses, the muscles in the diaphragm that assist in breathing and coughing may weaken. Individuals may experience breathing difficulty, respiratory infections and swallowing problems. Scoliosis is common. Many people with DMD may survive into their 20s or 30s. Becker's muscular dystrophy. It is less severe than but closely resembles to Duchenne's muscular dystrophy. This disorder usually appears around age 11 but may occur as late as age 25, and people with DMD usually live into middle age or later. The rate of muscle atrophy and weakness varies greatly. Emery-Dreifuss muscular dystrophy. The primary gene defect is a deficiency of the protein emerin, a constituent of the nuclear membrane, encoded by the EMD on the X chromosome. Expanded schematic of the nuclear and contractile proteins of the muscle. These proteins are referable to Emery-Dreifuss dystrophy and a number of the distal and congenital dystrophies, as well as several of the limb girdle dystrophies. Emery-Dreifuss muscular dystrophy. EDMD primarily affects boys. The disorder has two forms. One is X-linked and the other is autosomal dominant. Onset of EDMD is usually apparent by the age 10. Muscle contractures in the spine, ankle, knees, elbows and back of the neck usually precede significant muscle weakness, which is less severe than in DMD. Contractures may cause elbow to become locked in a flexed position. Nearly all patients with EDMD have some form of heart problem by age 30. Congenital muscular dystrophy. Congenital muscular dystrophy refers to a group of muscular dystrophies that are either present at birth or become evident before the age 2. Most people with this type of MD are unable to sit or stand without support, and some may never learn to walk. There are many genetic forms of congenital muscular dystrophy, including myrosin negative disorders in which the protein myrosin found in connective tissue that surrounds the muscle fibers is missing, or myrosin positive disorders in which myrosin is present but other necessary proteins are missing. Distal muscular dystrophy. Distal muscular dystrophy, also known as distal myopathy, describes a group of muscle diseases that primarily affect the distal muscles, those farthest away from the shoulders and hips in the forearms, hand, lower legs and feet. Onset of distal muscular dystrophy is typically between the age of 40 and 60. Although distal MD is primarily an autosomal dominant disorder, autosomal recessive forms have been reported in young adults. Willander distal myopathy preferentially involves the wrist and finger extensors. Miyoshi myopathy is unique in that gastrocnemius muscle are preferentially affected at onset. Facioscapulohumeral muscular dystrophy. FSHD initially affects the muscles of the face, facio, shoulder, scapular and upper arms humeral with progressive weakness. Onset is usually in persons teens but may occur as early as in childhood or as late as age 40. One hallmark of FSHD is that it causes asymmetric weakness, a particular pattern of muscle wasting causing the shoulders to appear to be slanted and the shoulder blades to appear winged. This is the facioscapulohumeral dystrophy with prominent scapular winging. Limb girdle muscular dystrophy LGMD. LGMD refers to more than 20 inherited conditions marked by progressive loss of muscle and the symmetrical weakening of voluntary muscles, primarily those in the shoulders and around the hips. Although 5 forms of autosomal dominant LGMD known as type 1 and 17 forms of autosomal recessive known as type 2 have been identified, at least. Some autosomal recessive forms of the disorder are caused by deficiency of any of the 4 dystrophin glycoprotein complex proteins called the sarcoglycans. Now let's talk about myotonic dystrophy. Myotonic dystrophy is another form of muscular dystrophy. Myotonia is an inability to relax muscles followed by a sudden contraction is typically found in this form of myotonic dystrophy. Typical disease onset is between ages 20 and 30. Muscle in the face in front of the neck are usually first to show weakness and may produce a hollow temples, drooping facial skin and a thin neck. DM1 affects the central nervous system causing cataract, early frontal baldness. DM2 is similar to the classic form but usually affects proximal muscles more significantly. So this is the classic myotonic dystrophy. You can see the frontal balding, hatchet faces, ptosis and wasting of sternocleidomastoid muscles, cataracts and gynecomastia. Oculopharyngeal muscular dystrophy OPMD. OPMD begins in persons 40s or 50s and affects both women and men. People first report drooping eyelids followed by weakness of the face, tongue and throat that can cause problems with swallowing. People who are severely affected by OPMD will eventually lose the ability to walk. Evaluations. Doctors review individual medical and family history to determine if the muscle symptoms that primarily affects other tissues or organs and whether they can identify an inherited condition. The team will also take steps to rule out muscle weakness resulting from prior surgery, exposure to toxins or current medications. The investigations include blood and urine test, exercise test, genetic analysis, MRI to examine muscle quality, atrophy or other abnormalities, muscle biopsy, immunofluorescence testing to detect specific proteins within the muscle fibers, electron microscopy to identify changes in subcellular components of muscle fibers, electrophysiology result may reveal electrical activity characteristic of muscular dystrophy. The treatment. Available treatments are aimed at keeping people independent for as long as possible and preventing complications that can arise from muscle weakness, reduced mobility, heart and breathing difficulties. Treatment may involve a combination of approaches including physical therapy, drug therapy and surgery. Drug therapy may be prescribed to delay muscle degeneration in muscular dystrophies. Steroids such as prednisone and deflazacort and immunosuppressive drugs can help slow the rate of muscle deterioration and damage to muscle cells but carry side effects that can be especially troubling in children. Mexiletine has been shown to reduce myotonia. In recent years, there has been a considerable progress in the development of genetic therapies that involve exon skipping to increase dystrophin expression. Eteplirsen is an exon 51 skipping drug administered intravenously that can be used in patients with mutations proven in that region of the DMD gene. So these are the wonderful concepts of muscular dystrophy. The other important concepts of clinical neurology I put in a book called Exam Oriented Clinical Neurology written by me, Dr.Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams. If interested, this book could be purchased The other book I wrote is Focused Neurology, written by me, Dr.Sreenivas, published by CBS Publishers and Distributors. This book will be very useful for students appearing for oral exams. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said, there are going to be about 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Just now we are done with the 35th episode of Prime Neurology. If you enjoy listening to these concepts, please like, subscribe and share my YouTube channel Dr. Sreenivas Medical Concept, which is India's leading neurology educational YouTube channel, and my web page Dr. Sreenivas Concepts. Thank you. Bye.